Hello, this is our second series on migraine. I'm David Kernick. I lead the Headache Initiative at the Royal College of General Practitioners, and I'm here with Professor Anne Macgregor of the City of London Migraine Clinic and Alison Frith, who was the headache nurse at the clinic. This second discussion, we want to focus on very much trying to get the diagnosis of migraine. How do we know that we actually have migraine? And our first step in understanding headache is really to classify it. And we classify it or put headache into two main boxes called primary headache and secondary headache. And Alison, I wonder if we could just start off by just saying a little bit about what is a primary headache and what is a secondary headache. So I think some people are confused by this differentiation.
Yes, they are. Primary headache is a kind of headache where the headache is actually the disease itself. And in our classification we talk about migraine, tension type headache and cluster headache, where the headache isn't actually caused by anything particular, as opposed to secondary headaches, which can be caused by infection, tumours or something else that's contributing to the headache itself. So it's a useful division to think about the different kinds of headaches.
Right, so a primary headache, there's some underlying problem with the biochemistry of the brain.
That's right, so it's a disease itself not caused by something else.
Right. Now there are a lot of secondary headaches out there. We're not going to talk about them, but there are one or two I would like to pick up on that I think it's important to recognise. And the first one is a bleed into the brain that we call a subarachnoid hemorrhage. That's a medical emergency and it's something we need to all recognise. And I wonder if you could just say a little bit about the type of headache that presents when someone has a sudden bleed into the brain like that.
Yes, it's a very different headache from migraine, and I think it's important to actually recognise that people can have both types of headache, primary and secondary. But those who experience a bleed into the brain, they get they describe as a thunderclap headache. Something, the worst headache that they've ever had, often right at the very back of the head, and they just feel so sick they need to call 999 and get straight to hospital. And recognising that is something that they've never had before. So it's a new headache. It's something very different from other headaches that they might have experienced, and I think just the worst and first is often the way that we describe the headache that goes with subarachnoid hemorrhage.
But of course everyone has to have their first attack of migraine, and in some cases it's difficult to differentiate between your first attack of migraine, which can be quite frightening out of the blue, and a serious headache like a hemorrhage.
Well, I think with the hemorrhage it is an instant headache. That's very different from migraine, which the headache will often be building up over a period of a few hours. Right,
okay. The other thing that's always in the back of everyone's mind, whether they're a patient or a healthcare practitioner, is does this headache represent a tumour? And Alison, I wonder if in your clinic, is that something that people want to discuss with you? Is that something that's in the back of their mind when they come and see? Do you always open that agenda up with them?
Very much so. People are very, very frightened that there is something very seriously wrong because they feel so awful when they have a migraine attack, and you almost believe that there is something sinister, as we say, growing inside your brain like a tumour, and people are very, very fearful of that. And part of our role in the clinic is to reassure people that despite how ill they feel, that most people do not have a brain tumour.
In fact, we now know the sort of risks that you have when you sit in front of your GP with a headache that's bad enough to consult. If you're an adult, your risk of tumour is less than 1 in 1,000, which is a very small risk. If you're under 18, it's less than 1 in 3,000. And in fact, very few tumours actually present with headache. I guess the question is, Anne, why don't we scan everyone that comes in to see us with a headache?
Finding out whether or not they've got a brain tumour or not, which, okay, you might clearly want to do a brain scan on that, is just recognising, saying to the patient, well, you have headaches that come and go. And if you have a brain tumour, it's going to get worse over a period of time. So you can't get well between bouts of brain tumour headache. And I think explaining to people that if we're looking for something on a brain scan, we already need to have some idea of what we're actually looking for. So from the story that they give of episodic headaches with being completely well in between, what would be the reason to do a brain scan? If we're examining people, very quick neurological examination, checking all the pathways of all the nerves that go through the brain can easily be done in clinic. And if those are all completely normal, again, there is no good reason to put somebody through a brain scan. I think when we're talking about brain scans, or even when patients are considering it, they may not be aware of how unpleasant it actually is to have a brain scan. And the fact that if we're going to give people what's called a CT scan, there is a dose of radiation that is involved in that. So it's not risk-free. Sometimes we're also finding things that are just naturally there within the brain that cause no harm at all, but identifying them on a brain scan may give some concern to that particular patient, an unnecessary worry. So I think we need to be careful about doing scans when there is a good reason to do them, and not when the story itself tells us that it's something that, however severe it is for the patient, is not something that should be investigated in a way that might put them at greater risk of something else.
I think this thing about finding incidental abnormalities in the brain is an important one. In some series that have been done by general practitioners, up to 10% of us have something inside our brain that we sail through life with quite happily, a little cyst or perhaps a little abnormality of blood vessels. And having found it, because these imaging techniques are now very sensitive, it leads to all sorts of anxiety. And I think that's very much overlooked. So I'm always very cautious to image or scan someone. I wonder if you could return now to the primary headaches, migraine, tension type headache and cluster headache. And before we really look at migraine, I just want to look very briefly at the other two. Tension type headache, very common, about 70% of the population have it. Alison, could you tell us a little bit about tension type headache? What is it? How does it present?
We tend to talk about tension type headache as a normal kind of headache that most of us get from time to time. It doesn't have the same features of migraine. It tends to be more of a diffuse kind of headache that isn't necessarily associated with feeling sick. And normally 1 or 2 painkillers will take it away. It doesn't normally stop you from what you're doing. So it's a normal kind of headache.
And is it often associated with tension, or is tension a bit of a misnomer, do you think? What's your feeling about that?
Some people do say that it's associated with tension. Quite often feeling stressed at work, hunched up over your computer, neck, shoulder tension can feed into it. But sometimes just having a walk outside, a breath of fresh air can be enough just to alleviate. So simple measures quite often can make tension type headache feel much better, unlike migraine, which needs much more aggressive treatments.
But a lot of people feel that tension type headache is on the same spectrum as migraine. A lot of migraineurs suffer from tension type headache. And do you think that in some ways these two things can overlap?
I don't know. I mean, when you're talking with patients, they can quite often clearly distinguish between the two different types of headaches. They'll talk about, this is my normal headache, and then they'll talk about, but this is migraine, which is quite different. And I think, in a way, going back to what Alison was saying, all the things that can trigger migraine are exactly the same things that give you a normal headache. So if you don't drink enough water, if you don't get enough sleep, if all those sorts of things, if you then push it too far into the migraine process, it'll trip into a migraine attack, which then goes on for several hours. Whereas a tension headache, you remove the person from the situation that was giving them the headache gets better, or they take a couple of painkillers. Mm-hmm. But with migraine, I would say that it's probably another step on from that tension normal headache.
And of course, cluster headache is very, very, very different again.
Cluster headaches are completely different ballgame.
I think cluster headache is the most painful condition known to medicine. And I said this in a meeting of GPs once, and I was rather put in my place by a female that got up and said, well, clearly you haven't been in childbirth. And I felt rather contrite. But recently there's been a study to suggest not as many females as males get cluster, but there has been a recent study to suggest by females that in fact cluster headache is far more painful than childbirth. So I was pleased to see that. But could you tell us a little bit about cluster headache? How does that differ from migraine particularly?
Well, you've touched on the pain already, and I have to say, when I saw my first cluster headache patient, I was absolutely terrified because I'd never seen somebody in so much uncontrolled pain. Whereas somebody with a migraine attack wants to lie still because movement makes the headache worse, somebody with a cluster headache finds that they just have to keep moving. It's constant motion because they just don't know where to put themselves. And these are, as their name suggests, clusters of headaches. Generally, the cluster will last for about 6 to 8 weeks. And within that time, they will usually get at least one attack of cluster, often a couple of hours after they go to bed, and maybe 1 or 2 attacks over the course of the day as well. But they build up very, very quickly with the headache. Then one eye goes red, the eye of the side of the cluster, and often they will get a discharge from their nose and from their eye as well, but completely split in half. So the unaffected side of the head is totally unaffected. And that can go on for a couple of hours and then disappear. And within the cluster, they can often still feel a bit bruised on the affected side. Alcohol will trigger it, sleeping will trigger it, getting too hot will trigger it. But outside of that 6 to 8 week cluster, they're absolutely fine.
And you don't get the associated features usually of nausea or vomiting or light and sound sensitivity that you get in migraine. And the pain, as you say, is much shorter and intense. They describe a red hot poker going through the eye, don't they, very often?
But it's the movement I always find. It's they just don't know where to put themselves. They're rocking, they're hitting their head on the wall, they're pacing up and down. Very, very different behaviour from migraine.
One of the astonishing things about cluster headache is how regularly they can occur on 1 or 2 times a year, like clockwork.
Yes.
And some patients can actually predict when their cluster bout is going to come, quite typically in spring or autumn time.
Yes.
They can go for several years without a cluster bout, but it's the regularity that can be quite astonishing, can't it?
Yeah.
I mean, I think the important thing is making the diagnosis of cluster headache, and it used to be many years until a diagnosis was made. I think now it's still about 5 years, and I think a lot of people get confused between what they call cluster migraine, because migraine sometimes comes in clusters, and cluster headache, and I think that can lead to diagnosis.
We don't talk about cluster migraine at all.
No.
Migraine can cluster in days of attacks, but cluster headache is very, very different.
I wonder if we can now just move on to the diagnosis of migraine, which is really important. As you say, Anne, earlier, a lot of people don't know they have migraine. What are the sort of features we'd be looking for with someone who has migraine?
Well, I think the headache is an obvious main feature, but I think people get a bit too hung up on it has to be one-sided or various other features that might accompany it. In essence, if people get recurrent headaches, they're otherwise fit and healthy. They're fine in between those attacks of headaches. But with those headaches, light bothers them, they feel sick, and particularly if they're unable to carry out their usual daily activities, that is a pretty good indicator that those attacks are migraine and not just a headache.
Alison, have you got anything to add to that? What are the diagnostic pointers that you find helpful?
The fact that migraine is recurrent and that people are very well in between attacks.
Right.
I think that's one of the key things.
Yes. So almost you could say any bothersome headache which you're free in between will be migraine.
And typically migraine, as we talked before, is very disabling.
Yeah.
It stops you from doing what you'd otherwise be doing, whether you were at school or at work or your leisure activities. It stops you in your tracks.
There are some slightly different features that we have to look out for in the younger age group, certainly out there in children. There do tend to be slight differences in migraine features. Do you just want to say a little bit about that?
I think shorter and sharper is the answer to that. Yeah. I mean, typically what you'll find is your child, and this can be a very small little tot to the teenager, will just go white, sort of pale, a bit listless, a bit quiet, and just want to go and lie down. Often just feeling a bellyache, stomach ache, rather than any major headache features. And that can just last for half an hour, and then quite often they'll be sick and feel absolutely fine and then go out in the playground again.
Yeah. So hopefully that'll give you a little bit more information, and you'll be able to decide whether you have migraine or not, although I suspect you probably didn't have much doubt. In fact, there has been a study suggesting if you think you have migraine, you probably have got migraine. And I think the other thing, of course, the family history is very important. If your parents or brothers and sisters had migraine, or if there's a strong family history of migraine, you're very likely to have migraine yourself. Okay, thank you. That's a little bit about the diagnosis. In the next section, we're going to talk a little bit about the migraine process itself, what's happening, the stages of the migraine attack, and how we can perhaps lead on to a little bit of a better management.